Welcome to this video on chest X-ray views. In this tutorial, we'll be exploring the different types of X-ray views used to evaluate the chest, and when each one is preferred. Whether you're a medical student, a healthcare professional, or just someone interested in learning more about diagnostic imaging, understanding these views is key to accurately interpreting chest X-rays. We'll cover standard views like the PA, posteranterior, and lateral, as well as specialized views such as the oblique, decubitus, and lordotic positions. Each view has its specific use, helping clinicians assess various conditions such as lung diseases, pleural effusions, pneumothorax, and more. Let's dive in and take a closer look at how each view helps provide a clearer picture of the chest anatomy and potential pathologies. Anterior-posterior view. The AP view is commonly used for bedridden patients or those unable to stand, such as in the emergency department or intensive care unit, ICU. If the patient cannot stand for a PA view, the AP view is performed with the patient lying on their back. Anterior-posterior view. Positioning: the patient lies supine on the midline of the X-ray table, with the arms abducted. The upper border of the cassette is placed 2.5 centimeters, 1 inch, above the root of the neck. The back of the chest shall be in good contact with the tabletop. Centering: it is done on midline to the sternal angle for upper ribs, onto mediastinum for lower ribs. Central beam is directed vertically at 90 degrees to center of cassette. Technique: KVP 70, MOS 30, FSS small, FFD 100 cm, no grid, cassette size 12 inches by 10 inches. Posterior anterior view. The PA view is the standard view for routine chest X-rays. It's commonly used for evaluating the lungs, heart, ribs, and diaphragm. It provides a clear image of the chest's anatomical structures. Posterior anterior view. Positioning: patient stands erect in front of a chest stand facing it. His neck is extended slightly and chin is placed on the chin rest, or on upper border of cassette holder. Back of his hands are placed on his hips. Shoulders are pressed forwards against cassette. It is ensured that trunk is not rotated. Patient is asked to remain motionless. Site is marked and X-ray beam is collimated. Centering: it is done on D6 vertebra level in the midline of back of chest, at a point midway between inferior angles of scapulae. The central beam is directed horizontally at 90 degrees to cassette. Techniques: no grid, FSS large. 1. Adult PA, KVP 65, MOS 20, FFD 180 cm, cassette size 15 inches by 12 inches. 2. Child PA, KVP 60, MOS 12, FFD 180 cm, cassette size 12 inch x 10. Lateral view. The lateral view is often performed in conjunction with a PA, posteranterior, view to provide additional information or clarify findings. For example, if there is a suspected abnormality, e.g. lung nodule, mass, or pleural effusion, seen on the PA view, a lateral view can help define its location more clearly, anterior versus posterior, upper versus lower part of the lung, etc. Lateral view. Positioning: patient stands erect in true lateral position, in front of chest stand. His shoulders are moved well back, hands and arms raised above his head. Patient is asked to remain motionless. Site is marked, and beam is collimated. Centering: it is done over mid-axillary line to the center of cassette, with central beam directed horizontally at 90 degrees to the cassette. Technique: KVP 75, MOS 40, FFD 150 cm, no grid, cassette size 12 inch x 10. Apical or lordotic view. The apical or lordotic view of the chest X-ray is a specific projection that is used to better visualize the apices, top portions, of the lungs. It is often preferred or indicated in the following situations: tuberculosis, TB, apical pneumonia or infections, lung cancer. Apical or lordotic view. Positioning: patient is seated or standing erect, facing cassette and chest stand. He is asked to lean back, making an angle of 45 degrees to cassette and chest stand. He grips the sides of stand for support and immobilization. Side is marked and beam is collimated. Centering, it is done in midline at D4 vertebral level. Central beam is directed horizontally at 90 to center of cassette. Technique, KVP 70, MOS 20, FFD 100 cm, no grid, cassette size, 12 inches by 12 inches. Decubitus view. A decubitus view of the chest, often done in the lateral decubitus position, is preferred in certain situations, particularly when evaluating conditions related to pleural effusion, pneumothorax, or other fluid accumulation in the chest. Decubitus view. Positioning, lying on the right, PA, or left, AP, side. The knees and hips may be flexed for comfort. The patient's arms should be extended over the head to prevent overlapping the sternum. The patient should be asked to breathe out and hold. Side is marked and beam is collimated. Centering, the central ray for a lateral decubitus chest X-ray should be centered at the level of the D7 vertebra. Beam is directed horizontally towards the patient. Technique, KVP 100, MOS 10, FFD 70 cm. Oblique view. The oblique view of the chest is used less frequently than the standard frontal and lateral chest X-rays, but can be very helpful in certain clinical situations. It's particularly preferred for visualizing the lungs and mediastinum, assessing ribs and pleura, pneumonia and other lung lesions, mediastinal and cardiac abnormalities. Oblique view. Positioning, the patient stands upright. The patient's side closest to the X-ray machine is rotated 45 degrees. The patient's arm closest to the machine is flexed, with the hand on the hip. The patient's other arm is raised as high as possible. The patient looks straight ahead with their chin raised. Side is marked and beam is collimated. Centering, the centering point for an oblique chest X-ray is above the diaphragm, at the level of D7. Beam is directed horizontally towards the patient. Technique, KVP 65, MOS 35, FFD 100 cm. Thank you for watching our guide on chest X-ray views. We hope this video helped clarify when and why different views are used in clinical practice. Understanding these X-ray positions is crucial for accurate diagnosis and treatment planning. If you found this video helpful, don't forget to like, share, and subscribe for more educational content. Feel free to leave any questions or comments below, we'd love to hear your thoughts and experiences. This is Shady signing off. Until next time, keep learning and stay curious.